Thank you for coming on the program. It's a pleasure to have both of you here with us today. So today we have with us Dr. Jimmy Coker, a consultant gastrointestinal surgeon from Sapphire Surgical Center, and Mr. Arofe, a survivor.
Thank you.
Thank you both of you for being here.
Thank you for having us.
Now, if I can start with you, Dr. Coker, talking about bowel cancer. It's something that always really, I'm always amazed by it, because I keep saying, when I was a medical student, I can hardly remember a case. And I was unethical. I'm not one of those who didn't used to go to school. I used to be this. So I can hardly remember it, but it seems to be so common now. How common is bowel cancer in our country today?
Thank you, Pamela. Yes, bowel cancer used to be quite rare when I was in medical school in Ibadan also, and same with other conditions like diverticular disease, which is wear and tear of the bowel. But with increasing adoption of Western lifestyle, bowel cancer sadly is getting more and more common in Nigeria. It is still not as common as one will find in the West, but it's common enough to become a public health problem.
Now, when we talk about bowel cancer, and we talk about Westernization, it's the diet, isn't it?
It's the diet, yes.
So what are the things that people need to look out for? Because all our young people have really, gone what I called over to the dark side. They don't even want to eat soups and, swallows and things that at least the older people seem to enjoy. But a lot of young people, they just want to eat pizza, they want to have chicken and chips. And, what are the kinds of things that, if you can put it in buckets, are the causes or thought to be the causes of bowel cancer, so that people can think about it, and particularly our younger ones can perhaps try and adopt those lifestyles?
So we would usually refer to this as risk factors, and there are modifiable risk factors and non-modifiable risk factors. The modifiable risk factors are things that we as humans can control. And number one is diet. Number two is diet, and number three is diet. And that's because lack of fiber in the diet over a period of time increases the risk of colorectal cancer. The other conditions that can contribute that are modifiable will include obesity, sedentary lifestyle, excessive use of alcohol, and smoking. So those are the modifiable risk factors with bowel cancer. The non-modifiable risk factors include age, because the older we get, then the more likely one is going to develop colorectal cancer. Others are hereditary, things that we inherit from our parents, including certain polyposis syndrome. So multiple polyps can occur, which is passed from one generation to the other. Others are things like inflammatory bowel disease, and certain operations can also predispose people to developing bowel cancer.
Thank you. Normally, in the program, I just like to ask you, as a person who has suffered from this syndrome, are there some of these factors that you would say you recognize as yours or not?
Definitely. Quite a lot of what he said I can relate to as part of my lifestyle then. So the fast food environment we're in now. So, and you find that it's actually a lot, you find when real food that is good for you costs a lot more than this fast food in most cases. So, and the tendency is you want to get something right now. The fast foods are the ones you can get very readily. The others take a bit more time. So you find yourself doing a lot more of that. A lot less exercising as well. So we find ourselves sitting down in front of the TV. You could be there 4 or 5 hours. You're at work. Most of the job is at the seat. So you're not moving as much as you can. Those are things I can relate to.
Thank you. I think it's so important that we talk about these things and say, what are the kinds of things and who is at risk? Because what we are finding, isn't it, is that a lot younger people And for me, that's very frightening. In particular, I think the gentleman from Wakanda sounds like if he's really from Wakanda, but he was he was such an icon, and all of a sudden they said he's dead. What of? Bowel cancer. So who's at risk?
Like I explained earlier, aging. So the older one gets, the more likely one is to develop bowel cancer. Anybody from the age of 50 onwards is at risk of developing bowel cancer. Sadly, risks are increasing in younger people also. And because of this, most international organizations have reduced the time to start screening from 50 to 45 years. And it's even getting lower. Wow. We do know that in our environment, both for breast and colon cancer, the age of incidence, the peak age of incidence is about 10 years younger than one sees in the West. So again, the screening age gets lower and lower, but at the moment, we will recommend screening for people 45 years and above, except if there's a family history.
I was going to ask that. Actually, you took the words right out of my mouth. How important is family history?
Family history is very important, but it relates more to the first degree relatives, so that father or either a parent or a sibling will be people who one would consider to be first degree relatives or children. So father, parents, siblings, and children. Then there are some families where there are inherited cancer syndromes, where there are 2, 3, 4 members of the family who develop a particular type of cancer, in this case, colon cancer. Especially if
and do you have that? Have you seen that here in Nigeria?
Oh, yes, we have. The syndrome complex is called the non-polyposis colorectal cancer syndrome. That is, they do have polyps, but not the numerous polyps that one gets with familial, the other inherited form of bowel cancer. And so these families also are prone to other cancers, like cancers from the renal tract, pancreas cancers, womb cancers, and small bowel cancers. So they usually need to be screened appropriately for all of those.
I'd like to talk about acceptance of screening. It's one of before we talk about the actual screening itself, in Nigeria, not enough people go for screening. So what are your thoughts as to why people don't go for screening? And, how important is it for us to change the minds of the public and have them accept screening as a natural part of what they should do?
Thank you. Screening is extremely important for certain cancers that are, one could refer to as silent killers, where symptoms, the patient may not complain of any problem. And for people who have not developed the health-seeking behavior, if there are no symptoms, then the assumption is that everything is fine. For bowel cancer, there now is strong evidence to show that screening saves lives. And there are a number of ways in which one can screen. Possibly the commonest will be checking the stool for evidence of blood or cancer cells within the stool. However, you can imagine that for some people, testing the stool can be socially unacceptable. So that's one of the reasons why people don't take up this form of screening. The gold standard for screening will be colonoscopy. Colonoscopy is a camera examination where the bowel is examined. Prior to that, one would have had to clear the bowels out, and then we have a real-time imaging of the colon where pictures can be taken, and also if we find polyps, we can treat those polyps at the same time to prevent bowel cancer.
Now that's very interesting, because we're talking about a lot of people who should come for screening, should come for cancer screening, And endoscopy is the gold standard. I must tell you that I've had my own endoscopies done myself. But the issue being that people don't like to do it. Now, can we talk about some of the symptoms that you get when you eventually things have advanced so that people listening can understand what it is, the progression from the asymptomatic to the symptomatic and how to recognize it?
Good. Thank you. So the first thing, the commonest, is blood in the stool. And a fair number...
Fresh blood or dark blood? What kind, people always say blood in the stool.
Well,
some people see those dark things and they don't recognize it as blood.
It's moot point, whether it's dark or fresh. It depends on the distance for which the blood has traveled and the speed at which the blood is traveling. Because there are people who bleed from a stomach ulcer who still get fresh blood. So it's important to appreciate that any type of blood in the stool is abnormal and needs to be properly investigated. And so blood in the stool will be, so check your poo to make sure
Some
that
people don't look
everything-
at their poo.
I know they don't.
They don't look at their wee.
I know they don't.
So if we
so
can
you
just...
got to check your poo, check your wee to make sure that it all is well. That's the first thing. The second thing is a change in the bowel habit. So the bowel, all of a sudden, if somebody who was going once a day before starts to go 2 or 3 times a day, or wakes up in the middle of the night to go, or is not going as frequently as they normally would. So any change in bowel habit, if persistent, say over a period of 4 to 6 weeks, then needs
That's
to be...
important, because when you said that to myself, I thought, I had a running tummy the other day. No, it's not about having a one-off.
Yeah.
It's got to be persistent, yes, over a period of time. So that's the second symptom. The third is tiredness, where people feel easily fatigued. And that's usually because there is slow bleeding into the bowel from the bowel cancer. So the blood count gets very low. And when the blood count gets low, which we would normally refer to as anemia, then the patient's energy drops, they're listless. So that's the other thing. The fourth is feeling a lump, either on the tummy or a prolapse in the anus where something comes out. Those are other features that, would
These are red
alarm.
flags that
Yes,
say,
those are red flag
go
symptoms.
to the hospital, go to the hospital now.
And those really are the common symptoms of people who may have bowel cancer.
Thank you. I think that's something that, we're going to perhaps talk a bit more about. What we'd like to do is perhaps hear your experience, but we'll be doing that after the break. Welcome back to Doctors on Air. In the first half, we spoke a lot about the importance of bowel cancer screening. We talked about the symptoms, people get it, the risk factors, and so on. And we're fortunate enough today to have Mr. Arolfi, who's a survivor. And I want to especially thank you because one of the things I've found is a lot of men don't like to talk. And I want to appreciate the fact that you're talking because a lot of men don't talk about illness. They see illness as a weakness. And I want to say that that your coming today for me is a sign of strength, it's a sign of courage, and we sincerely appreciate your being here. So if you could please share your experience of how you found out you had the condition and what you've done about it so far.
Thank you. Thank you for having me. Mine happened in 2023. Around July, I saw some blood in my stool. I'd been feeling a bit weak, so I went to my family doctor and he referred me to a gastroenterologist. I checked on him and apparently he doesn't come every day, so he comes on Tuesdays. So I was waiting for the following week when he would be there, but by that time I didn't spot any more blood. So I felt, nah, I'm okay, so I didn't bother. And that was July. And then in August, there was an incident where I went to the toilet and it was like a tap was opened. So when I got up, I was alarmed. So I just rushed to the hospital and I insisted I wanted him to come specially. And when he examined me, he asked me to go for a colonoscopy. I had that done almost 2 days later. And in the middle of it, the doctor just shouted. There was apparently a polyp that was actually blocking my colon. And he asked that I immediately also have a CT scan, because with the colonoscopy, he could see inside the colon, but he wasn't sure if it had grown beyond that. He said would be even worse. So I had it the same day, and they did a histology, because it took a piece of the polyp, and it was found to be cancerous. So when I got that, definitely everything seemed to collapse. Fortunately, I had my wife with me from that moment for every meeting I had with any doctor afterwards. And then I was referred to Dr. Coker. And he took us through very, very thoroughly what was happening, what needed to happen to address it. And I think about a month after that, I had surgery to resect about 6 centimeters of my colon, the descending colon. And after that, because I also chose rather than open surgery, I went for a laparoscopy, which meant in 3 days I was out of the hospital.
Fantastic.
So I was able to
And
go
this is here in Nigeria.
Here in Nigeria.
I think this is the important
yes.
thing you need to stress.
Yes.
This
here
is
in
all
Nigeria.
took place here in Nigeria.
In fact, my siblings are all in the UK, and they were insisting that I come to the UK. But my daughter, who is a medical doctor in the UK, told me to get my treatment here. So I had the surgery. And then I also had to go back afterwards to discuss with Dr. Coker, because they also did histology of the resected colon. And I was told I should also have chemotherapy. And I was referred to Luth. So I had Dr. Dio Joseph at the NCIA Cancer Center at Luth. I had 6 waves of chemo. I tell people that was even tougher than the surgery.
Yes.
I must be honest with you. But I had a very strong support system. My family, everybody came around. I had friends that I had not spoken to in years who all got in touch. And I think going to Luth itself helped with the healing, because when you see cases that are worse than yours, you don't have time for pitying yourself.
No pity.
You know, you see people younger than you, people who you actually wonder how they're able to cope. So that made me just tell myself to shut up and just, get the treatment and get better. So I had to put a kind of target in terms of, why do I want to get through this? I'm going to celebrate at the end of the 6th session when it's all clear. So the chemo was more about preventing a reoccurrence, because they also harvested some lymph nodes, and it was found not to have gone beyond the colon. So this was more about, in case there's anything else that was not visible,
around the system,
it should just kill everything. So I always quote what Dr. Dio Joseph told me. Said she didn't believe in mild chemo. She believed, let's kill the ant with a sledgehammer. Okay, let's kill it once and for all.
Yeah.
And so we went through that. It was 6 waves over a period of about 5 months. Tough, like I said. But at the end of it, when it was all clear, I was just so happy. And one of the things I decided to do from then on was to make sure I tell everybody about it. I've posted on my LinkedIn. I've tried to tell all my colleagues, once you're 50 and above, get a colonoscopy. You mentioned one of the issues we have in the country in terms of people getting the check. The average person, an executive working, goes for an annual checkup. The colonoscopy is not listed among the things that you get. So you get ECG, you get heart check, you get your kidney.
So
liver.
there's work we have to do with the insurance companies.
It's not listed. So you've got to ask for it especially.
Okay.
And most people don't even know about it. So that awareness is not out there. And that's very key. The earlier, I can imagine if I found this months before and the polyp was still small, it would have been taken out during the colonoscopy.
Yes.
And I wouldn't have had to go through surgery or chemo.
Yes.
So I tell people, get the check. The good news is there will be nothing, and you can rest easy.
Yeah.
But if there's something, better to catch it early, because it's going on 2 years now.
Can I
Yes,
say something? You mentioned about the work to be done with regards to colonoscopy and screening. Part of the problem is actually the capacity the system has to do safe and effective colonoscopy, because colonoscopy is as good as the person doing it. It's not the equipment, it's not the facility, it's the skill level of the person doing it, because there are risks associated with colonoscopy. So if they are not done in safe hands, there's a potential to cause harm for people who are otherwise well. I could use the example of when I was in the UK National Health Service and screening was going to be introduced. We had to do a driving test of colonoscopy, where you did the colonoscopy and you had two people observing you and scoring your skill levels and how you do it, patient comfort and everything. So that level of detail is not available here, and one therefore has to be careful to ensure that one goes to a right place where the colonoscopy can be done safely. Thank you.
That's really important. And I think what is lovely for me is, nowadays when we talk about cancer, we're not talking about a terrible condition that people don't know what to do with. We're talking about a curable condition. In fact, just 2 days ago, a friend of mine, a cousin of mine, sent a message to me saying, one of our cousins, our mutual cousins, her husband has mild cancer. And he's on chemotherapy now and should be better by March. No, I'm just saying the whole concept of mild cancer and a surety that he will be better by March is something totally revolutionary. And it's wonderful. And it just shows the kind of progress healthcare has made and new technologies, new techniques, picking up things. So, for example, maybe he had an early cancer picture. Who knows what it is? But he had mild cancer, and they are assuring me he'll be better by March after chemotherapy. So it's just wonderful. And this is why I really, wish more people would take advantage of some of these screening techniques.
So I posted something on LinkedIn 3 weeks ago, and
I saw it.
It was really very exciting. I've been back to Nigeria for 15 years, and most of the colon cancers that I get are fairly advanced. And this time around, we were able to operate on a screen-detected colon cancer.
Wow.
It was so small that we had to struggle to find it. And we had to put a tattoo there so that when we remove the colon using laparoscopic method, we're able to see, we are able to identify, and he's doing very well now. So that's really, I think, significant progress. And also intensifies or highlights the importance of screening, because anybody with colon cancer who has stage 1 or early colon cancer, surgery is curative in majority of people. So because of that, screening is key.
I think it's so important we think about this. And I wanted to just ask, what one action can our listeners, any listeners, take today to reduce the risk of cancer, particularly of bowel cancer? Talk directly to them.
Well, it's got to be diet, because that's a fundamental. So diet and screening will be, I know you said one, but they are equally important.
Okay.
So diet is the number one. We really need to change our diet. We need to ensure that we have high fiber in our diet. There should be lovely, plenty of colors on the plates, yellow, green, orange, just to ensure that we have enough fruits and fibers and vegetables in our diet. And the next is screening.
Mine is exercise more. If you are over 45, have a screening. That would help avoid a bigger issue in future.
Don't sit on your bottom, okay? If you have any problems like bleeding, blood in the stool, or change in bowel habit, please seek healthcare.
Seek appropriate healthcare is what I would say. There are different kinds of healthcare, but you need to seek the appropriate healthcare that you need. Thank you very much. It's been a pleasure having both of you on the program, sharing your experiences. And I think that our listeners have benefited a lot from listening to you talk and from hearing, what bowel cancer is. I think at this point, we can't overemphasize bowel cancer, because it's increasing and increasing and increasing. And the fact is that we do have what it takes to stop it from increasing. Simple dietary measures can take us so far. As you mentioned, exercise, and of course, for people over 45, we're talking about screening. And we want to say thank you very much to them for sharing their knowledge and experience with us.